think I'm going to get started. Yeah. Okay, welcome everybody. I'm going to discuss the strengths and limitations of population-based databases and comparative effectiveness research. It's a small group, so please feel free to interrupt me at any time. It'll be nice to discuss. So I'm going to start with just going over the definition of CER as defined by the Institute of Medicine. And it says CER is the generation and synthesis of evidence that compares the benefits and harms of alternative methods to prevent, diagnose, treat, and monitor clinical conditions or to improve delivery of care. The purpose of CER is to assist consumers, clinicians, purchasers, and policymakers to make informed decisions that will improve healthcare at both the individual and population levels. So, how do we generate and synthesize evidence? There are many different methods that feed into comparative effectiveness research. One of them is systematic review of the literature, and you see a lot of meta-analyses done in the context of CER. Another one is randomized controlled trials, and that's really the gold standard, and we'll go over that. And the third arm would be observational studies, and that's where population-based databases come into play. So randomized controlled trials, of course, they're considered the gold standard. They provide the least biased estimates. Why? Because it's randomized. All subjects in the study have equal chance to be in one arm of the study or another. However, consider the fact that RCTs will provide data on efficacy or outcomes in controlled settings rather than the real-world settings, and that's very important because there are very stringent rules by which RCTs should be conducted. And RCTs are not always feasible or ethically acceptable. Sometimes you would have rare conditions, and so it's very hard to have adequate accrual. You have vulnerable populations, and it's ethically not feasible to have RCTs. I would mention here, for example, pregnant women and in some cases, children as well. And so this is where observational studies can fill some important gaps. First of all, with observational studies, we're going to get data in real-world settings. So the rigid settings of clinical trials will not be applied here. It's in routine clinical practice. You're going to have some non-compliance, you're going to have compliance, you're going to have many different things come into play, but it's real life. That's what happens in real life. You'll also be able to study rare conditions because in population-based databases, you're going to have very large numbers, and so you are going to be able to capture some rare conditions. And especially in some databases, you're going to capture the experience of some vulnerable populations, such as in the Medicaid database, or the Medicare with the elderly and disabled populations, or the end-stage renal disease. And also, you'll be able to compare a number of treatment alternatives, especially when randomized controlled trials are not feasible. Okay, so with population-based databases, we're therefore going to have data on large number of subjects and at an affordable cost. I mean, you would not be able to do primary data collection on thousands and thousands of people. And so it's right there, readily available, it's been collected, and we're making the best out of the data that's available. Usually it's at a very affordable cost. I say usually because if you try to get Medicare data for many, many years and many types of files, then the total amounts to quite a high amount, and sometimes it's unaffordable. But for the most part, you can get it for affordable cost. You have a longer period of follow-up to examine long-term risks and benefits, especially in the case of Medicare beneficiaries, for example. Older people get enrolled in Medicare, and then they stay in Medicare until they die. And so you have a very long period of follow-up for these individuals. And you are going to have a perspective on the scale of, or the magnitude of the problem or benefits from a treatment at the population level, and the variations in these risks and benefits at across the nation. And so that's also a very important consideration in population-based studies. Most importantly, and I talked about this earlier, you're going to get data from routine clinical practice, from care delivered in real-world settings. And this, for example, what comes to mind is post-marketing surveillance. Okay, you're going to have a lot of phase 1, 2, 3 studies, and these are all in clinical trials, and you're going to obtain some kind of findings. But then how does that apply in real-world setting? And speaking of post-marketing surveillance, so our pharmacoepidemiology guru, hi Sharon. So I think for post-marketing surveillance, population-based databases offer are very important resources. There you can see how it is applied to the total population, how rare adverse events can be captured, and so on. So some examples of population-based databases, and here my talk is really going to focus on the contents of data and how we would be able to capture some of the outcomes and treatment and so on, rather than tackling the statistical or analytic techniques that we need to apply in order to take care of selection bias. I'll talk about that very briefly at the end. So it's mostly about the content of the databases. So one source that's used very frequently is the enrollment and claims data, administrative data coming from Medicare and Medicaid, from the Veterans Administration, and from private insurance to a lesser extent. But Medicare and Medicaid, as well as VA data, are used very frequently to do various kinds of observational studies. In the Medicaid database, you're going to have a representation of the poor, of the aged, of disabled, but also a lot of children and women of childbearing age. In the Medicare database, you're going to have the aged, the disabled, also people with end-stage renal disease. With Veterans Administration, of course, it's the military population. With private insurance, people who have been insured through the private sector, and these are people who are employed for the most part, and they're getting insurance through their employer, and you'll have their dependent as well. Yes?
Available to anybody in any form or not?
You need to be part of the VA system in order to get access to it.
But
the others you don't. Yeah, you purchase them, or if you have some relationship with your state Medicaid agency, you would be able to get them. But you need data users agreement, and that's a very stringent process to go through. Then we have this discharge data, which is the Healthcare Cost and Utilization Project. I'll talk a little bit about this. It's discharge data, and one of the most interesting aspects of HCUP data is that it's all payer data. So whether it's the uninsured, it's Medicare, Medicaid, or the privately insured, they're going to be represented in the HCUP data. And you have longitudinal survey data. The one that I'm most familiar with is the Health and Retirement Study. And we'll go over this a little bit as well. It's a very rich data on older adults, 50 years of age or older, a US representative sample of adults, so a very important resource. And then you have a bunch of registry databases and vital records. So you have the surveillance, epidemiology, and end results. For those of us who do a lot of studies on cancer epidemiology and health services research, we use the CER quite a bit, and the equivalent of the CER in Ohio is the Ohio Cancer Incidence Surveillance System. We have birth and death certificate records, and we have other disease registries. I know, for example, of the cystic fibrosis registry. So those are very important resources as well. In addition, we have linked databases, and the linked databases are very, very interesting because they build on the complementary strengths of different sources of the data. And so, for example, you have the CER and Medicare data. So instead of having data only on tumor characteristics and when cancer was diagnosed, et cetera, all of that data are linked to Medicare data so that you can also look at access issues, you can look at disparities across different populations in health services utilization, their outcomes, et cetera. So that really leverages the strength of both databases. Another source that was developed here in-house is the Ohio Cancer Aging linked database. And what we did to develop this particular database is to link data from the Ohio Cancer Incidence Surveillance System with Medicare, Medicaid, as well as clinical assessment data from home health care and nursing home care. And what this does is that there's some very interesting data, for example, in the clinical assessment data from home health care, as well as from the nursing home care database. And it allows us to better characterize our patient population, something that we cannot easily do with claims data. And then another example that I would like to mention is the linked health and retirement study and Medicare data, and this is very, very rich data. So the health and retirement study portion of the database would have all the survey data, which would make it possible for you to characterize an older person's clinical presentation in great detail. But also all of that is linked to Medicare data so that you can also look at their health services utilization and many, many other outcomes as well. So enrollment and claims data, what do they include? For the enrollment data, you're going to have demographic variables, you're going to have different eligibility categories so that you can tell in Medicaid, for example, who was enrolled in Medicaid as a result of just being poor versus those who were disabled, for example. And in the context of Medicaid program in particular, these variables are very, very interesting, especially the length of enrollment in Medicaid, because in some of our studies, for example, we have shown that the longer people are enrolled in Medicaid, the more likely they are to access certain preventive services, and that affects outcomes as well. And we also look at gaps in enrollment, and this is also very important because there's a lot of churning in the Medicaid program, so people come in and out quite a bit, and that really poses a great deal of methodological challenge in defining our study cohort. The area of residence is very interesting no matter which database you use. What it allows you to do is to look at the contextual variables. So where does the person reside? What kind of characteristics does that community have? What kind of resources is the person, does the person have access to? What is the poverty rate, the unemployment rate, et cetera? So this has really gained a lot of interest in more recent years because where you live has a lot to do with what kind of care you receive. And so what we do here is that a lot of times we geocode their residence address and then we go to the census data and obtain all the relevant data from that source and then run the analysis accordingly. In claims data, so these are billing data. They were not collected for the purposes of health services research, but we use them for that purpose. But there are some very pertinent data that we use on a very regular basis that are at the individual and at the encounter level. So you will have dates of service, which are very important because you would like to look at events in relation to other events, or you have to set your index date, for example. You have diagnosis codes that are recorded at the encounter level, the procedure codes, what kind of care did the person receive. This is how you identify, for example, the type of surgery, the type of different diagnostic evaluations that the person undergoes. And then you, in some databases and more recently in Medicare data as well, you have prescription drugs. And so you will be able to get a pretty good idea of what kind of care people are getting just by looking at claims data. What are the applications of administrative data in comparative effectiveness research? There are lots of examples. I'm just going to list a few here. Basically, you're going to be able to compare treatment outcomes between patients who are administered treatment A versus treatment B. Okay? So we've been looking, for example, at surgical interventions, laparoscopic versus open surgery for colon resection. How do the outcomes vary between the two groups? What are, is it affecting length of stay? Is it affecting readmission rate? Is it affecting complication rates, and so on? We can look at different pharmacological treatments, and here we can compare a drug regimen A versus drug regimen B, and the outcomes down the road. And then we can also look at combinations of treatment modalities. So, in prostate cancer, we look at radiation plus surgery versus surgery alone versus any treatment compared to active surveillance, for example. So that's how we use it. We're currently working on some epilepsy outcomes, and what we would like to know is whether people who undergo surgery for intractable epilepsy have a better chance to be on a much more simple treatment regimen after surgery, and maybe not seek care or emergency room visits as frequently as they did prior to surgery, for example. But there are a lot of idiosyncrasies in population-based databases. And so one kind of set of strengths that applies to one particular database is not going to be the same as what you apply to another database. So consider, for example, that as I mentioned earlier, the populations represented in the databases are going to be very different. So whether you look at Medicare versus Medicaid versus private insurance, et cetera, these populations are going to be very different. Another thing that's very important is how well are we able to characterize the clinical presentation of study subjects. And this is going to be very important because it will affect the way we are able to do risk adjustment. Okay, and we'll go over this in detail in a few minutes. How treatment can be identified and how much detail do we need in order to effectively compare treatment A to treatment B. And maybe the level of detail that's in my database will not be sufficient to, will not meet my needs. And also, what kind of outcomes are we tracking and how often? And that's also going to be very important. So populations covered in a given database, that's what's going to dictate what kind of questions you can answer with the use of that particular database. So for example, if you're working with Medicare data, by definition, you're going to work with data for people who are aged, blind, aged disabled, they can be blind too, and ESRD, end-stage renal disease population. That's just by definition, because these are people who are eligible for Medicare benefits. What is convenient about these data is that, for the most part, these individuals are enrolled in the program, and then they stay in the program until death. There's no loss to follow up otherwise, especially with the elderly population. They're just going to stay in the Medicare program until death. This is a database that's very well suited to study chronic conditions and conditions that pertain to the aging population. However, bear in mind that the drug benefits were not offered until 2006, and so that's going to have some limitations in your study design. With the Medicaid data, by definition, these are people who are disadvantaged, whether they're poor, aged, or disabled. They're just very, very vulnerable people. However, also consider that it's a diverse population. We need to think about the very large representation of children and pregnant women in the Medicaid program. And so you're going to have, most of them are going to be healthy. And so you can do a lot of different analysis on that population. It's a healthy population. And you also have the near poor, because the Medicaid program was expanded over the last several years to include people with higher incomes. Also, consider the fact that minority people are overrepresented in the Medicaid population, and also the people who have special needs. So those are, and this ties back to the disabled population. So a lot of the people with disabilities, including functional limitations or mental illness that is disabling and prevents them from being able to have to be employed. People with intellectual and developmental disabilities, all of these people are going to be represented in the Medicaid program, or disproportionately represented. But a sizable proportion of these people, and to a lesser extent for the disabled population, but more so for children, they're going to come in and out of the program quite a bit. And that's really going to pose a great deal of analytical challenge. And so, for example, in our analysis, and this is something that we've been struggling with quite a bit in with the epilepsy project. So when you're defining your study cohort, would you, the easier way to go about would be to say, I'm going to account for people who've been enrolled from point A to point B continuously, okay? And that period can be quite long. But, like I said, you're going to have a lot of people who are going to come in and out of the program. And so when you set your criteria to have continuous enrollment during that time period, first of all, you're going to reduce your sample size quite a bit. But more importantly, what you're going to have is probably end up with a study population that looks very different from the ones who come in and out of the program quite a bit. And so the potential to introduce some selection bias here is going to be very, very important. And that's something to account in the analysis. And so one of our students is really going to look at the different ways by which we can capture people who come in and out of the program, and compare those compare the findings to those who are continuously enrolled in the program. Are there any questions? I'm happy to entertain questions as we go along.
Are you going to talk about explorers later on?
No, I'm not. No.
Do you know its availability? I know it's available to people at university hospitals. What about cases?
I don't know the answer to that, but I know that at Metro Health, for example, we have been collaborating
Well,
with
hospitals, yes.
Yeah.
But those people who don't have hospital appointments, can they get to use explorers through our CTSA?
I don't know the answer to that. I believe the answer is yes, but you need to have a collaborator within the hospitals.
Okay.
All right. So discharge data from the HCUP. This is a very interesting database. Like I mentioned earlier, this covers all payer data. Whether you are uninsured or privately insured or Medicare or Medicaid, you will be covered through the HCUP. And you have a sample of the HCUP that's covered, and that's 20% of actually hospitals participating in the HCUP. And it's a stratified sampling at the state level, and 20% of the hospitals are selected. And once the hospital is selected, all of the discharges contribute to the database. And in any given year, you would have something like 7 million admissions covered in the National Inpatient Sample. But we also have the state inpatient databases, which cover 100% of discharges in a given state. And that makes it very, very rich. Not only that, but for a state like California, and I believe also for New York, what they've done is they've not only made the inpatient discharges available, but also discharges from the ambulatory care settings and also from the emergency departments. 100% of inpatient, ambulatory care settings, and emergency department. And whereas in the past we were not able to identify multiple admissions for an individual in the SID, the newer setting, especially where they've combined all of these databases, you should be able to identify various encounters for the same individual. So if an individual got ambulatory care or a visit to the emergency department and then got admitted to the hospital, you should be able to identify all of these encounters because they've been linked together. And yeah.
What is the link? Is it Social Security number?
No, it's a dummy number. We don't know anything about it. It comes with the database.
So it's a pretty good linkage.
Yes. Well, yeah. Yeah. As far as I know, it's a very good linkage, yes.
What kind of fields come across?
You're going to have diagnosis codes. You're going to have procedure codes. You're going to have some dummy date variables whereby you can say the patient was readmitted within 30 days, within 60 days, or whatever, or 42 days. You're going to have demographics. You're going to have hospital characteristics. And I believe that in some instances, the county is also available so that you can link it with the area resource file, right? That's what Nick is doing. And you can also link the data with the American Hospital Association database by the AHA ID so that you can pull hospital characteristics. You can do volume outcome kinds of analysis even at the surgeon level. So it's fairly rich. But again, keep in mind that especially if you're looking at the uninsured data, there are not too many sources that are going to give you this level of detail. All right, longitudinal survey data, and I'm going to focus here on the health and retirement study. It's a US representative sample of older adults age 50 or older. So what's interesting here is that you're going to have the pre-Medicare population as well as the Medicare eligible age group. Okay, and this is important because, for example, I have some colleagues in the Department of Sociology who've been looking at what they call cumulative risk index, whereby they look at what kind of risk factors people enter the Medicare program. Okay, it's not just because everybody turning 65 is going to enter Medicare, but what kind of baggage are they coming with to the Medicare program? So it's a really interesting perspective. And also in this particular database, the minority individuals are oversampled, and so you have quite a few African Americans and Hispanic respondents to work with. Now with the registry data, I mentioned about the CER. The CER is going to cover incident cases of cancer in select geographical catchment areas, and it covers about 26% of the US population, has a very high rate of completeness and very, very high quality data, and it covers all age groups. Just by using the CER, you should be able to get the cancer anatomic cancer site. You're going to have the stage, histology, a lot of details on the tumor, but also, of course, demographics, but also the vital status, or yes, the vital status of the patient at a certain follow-up period. So you're going to have the date of death and the cause of death as well. So you can do a lot of very detailed survival analysis. And then you're going to have the birth and death certificate data, and these are going to capture nearly all of the births and all of the deaths that occur in a given state. And it's fairly rich if you're interested in obstetrical outcomes, just to use the birth certificate data. And then for death data, we usually end up using just the date of death and the cause of death, and that's it. Okay, so now we go to the contents of the database, And what's included in the database is going to dictate the way by which we are able to characterize our study population. Okay, so in administrative databases, we have limited ability to describe our study population. And by that I mean inability to characterize their health status, their functional status, their cognitive status. The clinical data are not available. For example, BMI would not be available there. Some of the important behavioral variables are not recorded in a consistent manner. We can look at comorbid conditions, but consider the various sources of bias in the documentation of these conditions. You can have overcoding, undercoding, et cetera. And also consider the fact that comorbid conditions are identified as present or absent, and there are no severity measures, and that's a very important limitation. So for example, you can have a code of congestive heart failure, but whether congestive heart failure is limiting the patient's ability to ambulate, to carry out certain activities, we will not be able to tell. A CHF patient looks like a CHF patient in this kind of databases. So other databases are going to offer longitudinal such as the longitudinal survey data are going to offer the ability to describe your study population in a much greater detail, albeit at predetermined intervals. And so in the HRS, you're going to have very detailed data on their functional status, on their health status. Their cognitive status is measured. Their depressive symptoms are collected. You have data on their visual impairment or hearing impairment. You have many different kinds of variables that you can use to characterize that patient's clinical presentation at some index date. But it is recorded every 2 years, okay? And does that really serve your analytical needs? Then you have the registry data, for example. So the registry data, like the CER, is going to have very detailed data on cancer, but it will not carry any data on the comorbid conditions. And so you will not be able to really characterize the patient's clinical presentation. The death certificates, and I have not really worked with the multiple cause death certificate data, but beyond the underlying cause of death, and if that's recorded accurately, even that, you're going to have very little information on the decedent's health. And then the birth certificate data can offer some insight, can offer some insight on the mother's physical health and behavioral factors. And then there are a number of detailed measures on the infant's health. But that's usually at a cross-sectional level. And then you'll need to maybe track back the mother in some other database to collect more data, or track the infant forward to collect additional measures. So treatment data, what kind of detail do you need for your analysis? I don't know. So for example, I've been talking to some surgeons, and they've been asking me about some materials that are used intraoperatively. Okay, what kind of mesh are they using for abdominal wall repair? Is it hands-on versus stapled or whatnot? The kinds of medications dispensed, including dosage and refills, those are available in our database. And you can identify the type of surgical procedure performed and, with some detail. Now, sometimes you can't really, so for example, in prior years, it was not quite possible to rely on ICD-9 procedure codes to be able to identify laparoscopic versus open procedures. You really needed CPT codes, and then the CPT codes were sitting in a different file from the physician claims, et cetera. So there are some idiosyncrasies like that need to be sorted out. But you can identify the kind of surgical code, the surgical procedure, but like I said, some of the details will be missing. As far as pharmacological treatment is concerned, so if the drug is received on an outpatient basis, I think you should be able to capture it pretty well, including the dosage, the refill time, and all that. But if it's more difficult to look at treatment that is administered in an inpatient stay. And also, for example, if a patient is receiving some drugs directly from the manufacturer, like in some cancer patient cases, you would have difficulty, you would not be able to capture that whatsoever. Other treatment issues, so for example, the flu vaccine. A lot of times we say, well, who are receiving and who are not receiving flu vaccine, and then we would look at the Medicare data. But if the patient got flu vaccine at the local grocery store and that was administered as part of their community outreach, then Medicare was not billed, and I would not be able to capture that vaccine, and the patient would be misclassified as no vaccine. Digital rectal exam, we struggled with this quite a bit in looking at active surveillance in prostate cancer patients, because part of rendering active surveillance is to perform digital rectal exam. But the reimbursement for digital rectal exam is so low that many providers would not even bother putting it on the claim. And so you would, again, misclassify the patient as no digital rectal exam. Same with fecal occult blood test, for example. The reimbursement is so low that they wouldn't bother putting it on the claim. Now, outcomes. This is also very important, because here are the data that are available, and here are the data that are missing. So what's available? You have a lot of data on health services utilization. So let's say you're comparing laparoscopic and open surgery. You're going to have length of stay, you're going to have the readmissions, the transfer and discharge status, the charges, reimbursement, the costs, et cetera. You may even be able to document the adverse events to the extent that they're documented in the claims. But what is really missing, and that's a big handicap, is that we don't have any patient-related outcomes. So we don't have symptoms, for example. And so if you're looking at chemotoxicity, just to give you an example. Okay, so suppose a patient had nausea, but the patient never sought care for nausea, and there was no office visit or there was no admission for nausea, then I would never be able to capture that, because I don't have access to the patient to ask the question, did this cause nausea? Also, we don't have test results whatsoever. So you can, if you're doing some kind of surveillance as you administer a treatment, you can tell whether the patient had liver functions and all that tested, or kidney functions, but we don't know the test results. Okay, we can just say that that particular test was performed. This is where electronic medical records come as a very nice supplement to claims data. From survey data, you can have patient-reported outcomes. So in the case of health and retirement study, you're going to have the patient's health status that's reported on a regular basis. You're going to have functional status that's measured on a regular basis. The patient may report depressive symptoms, may report incontinence or falls. You're going to have all that captured. Okay, but in the case of falls, for example, and when you're looking at administrative data, you would not be able to capture that unless there was maybe a fracture. Okay, and then you say, well, even then, I don't know if it was a fall or not. But consider the richness of data when you end up linking the health and retirement study with Medicare data. Then I think you're going to have a lot of patient-reported outcomes, as well as outcomes that can be derived from administrative data, which makes it a very interesting resource. But as I mentioned, I just touched on this earlier. Consider the fact that the reported measures that you're going to find in the HRS or anywhere else are determined. You're not the one defining them. You're not saying, okay, here's the kind of measure I would really like to use in my study. It's been measured by some way, that was decided by another group, and then you are the secondary user of the data. And they may or may not meet exactly your analytical needs. Same thing, the measures are reported at intervals that may or may not be best suited for your study. And coming back to the chemotoxicity example, I would really like to have some of these data elements recorded maybe every 3 months, maybe every month, I don't know, for a certain period of time, and then maybe at longer intervals afterwards. But in the health and retirement study, they are documented every 2 years, and I'll just have to go with that. And there's nothing I can do about it. A very, very important point in methodological studies is selection bias. We talked about the randomized controlled trials as being the gold standard in epidemiological and health services research studies, but as I said, we don't have that luxury all the time. And while I focus most of the talk on the contents of these databases, I don't by any way want to minimize the fact that non-randomization is going to really yield some selection bias, and it's very important. So you're going to have certain patients and certain provider characteristics that are associated with receipt of a certain type of treatment or another. Okay, so maybe laparoscopic surgery is going to be or affluent patients, and those going to higher tech hospitals or teaching hospitals or whatever type of hospitals will be more likely to undergo robotic surgery versus non-robotic surgery, laparoscopic surgery versus open surgery, this kind of state-of-the-art treatment versus not. And so you have no control over who got what kind of treatment, but you will need to account for that selection bias in your analysis. And typically, these are the techniques that we use in, to address selection bias, and that's propensity score and instrumental variables. For propensity score, that's just a way to address the imbalance of patient characteristics across the two groups of treatment A and B. And so it's a way to turn that into a quasi-experimental design using observational studies. And we have an expert, Dr. Dawson can speak to that as well. Okay, in summary, despite the many limitations, population-based databases can be great resources that can fill important gaps in comparative effectiveness research. Okay, going back to one of the earlier slides, we had meta-analysis with systematic literature review, and we had RCTs, and then observational studies are there to fill a lot of the gaps. Without using population-based databases, we cannot gain a perspective on the magnitude of the problem. A lot of the lines, for example, in the United States in 2009, this many people underwent this and that surgery and whatnot. Those are all come from population-based databases, but it really puts things in perspective and say, oh, okay, so this is the kind of magnitude that we're talking about, and this is how significant this particular health problem is. And also, I think this is very important, we would not be able to examine variations in practice and outcomes of care. And here I mentioned about the Dartmouth Atlas, for example, and how they documented all these variations, which is really important and interesting. The best way to overcome some of these limitations, and I really value the richness that linked data bring to our analysis. You can really link different kinds of secondary databases, and with complementary strengths, you capitalize on the strengths that each of the databases will bring. But also, more and more, what we're seeing is that there's primary data collection that is kind of appended to the secondary data. So you have a lot of survey data or databases that capture patient-reported outcomes, and then those are linked with claims data or ideally EMR data as well. So this would be pretty nifty, but it would be a very major undertaking. So suppose, and we had a pilot grant to link Medicaid data with EMR data, but just the bureaucratic obstacles are so humongous that at least right now it's not feasible. But we've thought about different ways to overcome these obstacles, but it's been a very difficult road. And also, for example, when you are obtaining data from Medicare or Medicaid, you assure them that you will never contact patients. But the other way could be very interesting too, that you have a cohort of patients that you're taking care of in some kind of care setting, and then you can ask for the administrative data for that cohort of patients, and that's perfectly feasible as well. So I'm going to stop here, and I'm open to questions. And here is our website, which is still under construction, but please feel free to visit or the website or to contact me for any questions. Thank you. Questions? Yes, sure.
Do you want to say anything about those databases that are like almost population-based, like electronic medical records, like from the UK, which is like near and dear to my heart. But I know there's if we have access to those data, that can be a source of almost population-based data.
Yeah.
Anything to say about that?
I know very little about some of these databases, and we had a student who came and, a former student, then he went to Merck, and apparently for their post-marketing surveillance studies, they accessed the UK data quite a bit. And he always told us about how rich these data are and whatnot, but I have not had the chance to work with these databases. In particular, what really stayed with me was that he mentioned that it wasn't that difficult to get access to them. Is that your experience as well?
Well, I was lucky. I was working in a place that already had it. And
Oh,
already
okay.
had a relationship with them, but I think that they would be willing to work with people. I mean, on paper, it's really expensive, but they have an interest in having their data used for research.
Yeah.
Like any other database, there's strengths and weaknesses. But I'd be happy to talk to anybody about it. And I could say a little bit more.
Please.
I mean, in April.
Oh, in April, okay.
But I mean,
Yeah.
because it was a long project, but like anything else, there's strengths and weaknesses.
Yeah.
There's things that the data have, and there's things that
Yeah.
they don't.
But does that cover the entire UK and?
It's not quite population based.
Okay.
I mean, the people tend to use the same provider, but they don't have all the data for everybody. And there's a couple different competing companies that have data that are somewhat overlapping. So
Okay.
it's not as simple as you might hope it to be.
Somewhere that might also, because it's also got a national health service, Saskatchewan.
Right.
Yes,
But,
Canada has
Ottawa,
multiple.
Ottawa, yeah.
Well, is it all the Canada? It's not all of it.
Manitoba. Well, I've seen studies from Manitoba, from Saskatchewan, and then British
Yeah, they
Columbia.
have.
I don't know if all of these data have been compiled into one big Canadian database, but I've seen data from different provinces.
So, NIH has, over the last few years, got a lot of databases with genetic data. Have they ever found any databases for non-genetic data? Do you know? NIH, I don't know if they have one or not. For
wouldn't be able
example,
to comment.
right now, you do any genetic study with a lot of genetic data, if it's funded by NIH, you're going to put it on one of their database. They don't do that for epidemiological studies, do they? They've never done that, have they? NIH.
Well, there is something called, and I don't know if I'm interpreting your question correctly, but resource sharing plan. So when you have come up with a database, then you make it available.
Yeah. Does
Yeah.
that have to go, but that doesn't have to go into an NIH database.
Are you
This-
thinking about
What?
clinicaltrials.gov?
Oh, critical
Something
trials,
like that.
that's
Yeah,
right.
I don't think, correct me if I'm wrong, but I don't think there's a requirement yet that epi studies have to go
Yeah.
on clinicaltrials.gov.
But
I
there's
think it's like a
DB-GAP for
volunteer.
all the genetic stuff.
Yeah. Is there?
Well, on the other hand, there is something in, when you're preparing a grant application, there's something called resource sharing plan, and what you do with the data that you develop.
Right.
It's always very perplexing to me because it's so difficult for us to access the data, and we swear to never share the data and all that, but
Use agreement, so you can't.
that's right. And so I usually put down something like, well, it has to go back to people who gave us the data.
But this is very much for people who are getting a lot of NIH money for doing genotyping.
Yeah.
They have to put it in.
So when you say population-based databases in genetics, so you have a whole bunch of samples on a...
It's typically case control.
Hmm.
10,000 cases, 100,000 controls, God knows what, terabytes of information. Or petabytes, whatever they are. I mean, it's horrendous to know what's got there now.
Considered by HCUP or anything by the government, for example, or are they planning on looking at particular surgical interventions and looking at doing more in-depth data on them? Is there anything, anything on the forefront?
I haven't seen anything along these lines, although, the patient outcomes research teams, maybe the port people, I don't know, Neil, would you know anything about that, or? I'm not aware of that. No. All right. Thank you all.